Other imaging, MRI, when it first came out, was going to be the way to go. It is not the way to go. It reflects edema only. Okay? Edema is not specific for infection. It can be due to many things, as you know. And in those difficult cases that we have, where there are other processes going on, like overlying cellulitis or anything else that will increase edema in the area around the bone too will become edematous, and the MRI will be abnormal, and it will be read as inflammation in the bone. And inflammation of the bone sometimes is written as osteomyelitis, which becomes a problem. We don't have that problem with our radiologists here, but it is very commonplace elsewhere. So it's really not of really good value in those complicated cases where we need it most. Those with contiguous infection and cellulitis, those with overlying skin ulcers, neuropathic osteoarthropathy, recent trauma or surgery, or those who have fractures or non-unions. Here is the hope of the future. When the MRI was early and we didn't have enough data on that, we thought that was the hope of the future. This study is in the exact same position. We don't have enough data to find out where its vulnerability is, but fluorodeoxyglucose PET scanning is really, really good on the very small number of cases that have been looked at so far, with high sensitivity and specificity. As you know, it measures metabolic activity as well as giving a spatial delineation, so it has the possibility of being the optimal evaluation. At the present time, it's extraordinarily expensive. It's also not covered by most patients' insurance unless they have lymphoma or some reasonable rule-out lymphoma type of diagnostic procedure going on. If there's a way in which you can include rule-out lymphoma in your workup, then you can get a PET scan. It may be helpful in these situations. We await more data. So, in terms of how you go about diagnosing the different forms of osteomyelitis, I've given you big hints along the way. Hematogenous infection in childhood, you can't use the x-ray. You get it initially just to make sure you're not missing a bone tumor or something like that. But then you get the bone scan. Bone scan is positive. You then put a needle directly into that bone and make the diagnosis, both histopathologically and microbiologically, and you put the patient on antibiotics that night. Acute hematogenous infection in adults is a much longer presentation period. X-ray is very helpful. Then you go and do percutaneous biopsy, and if that fails, you do open biopsy. Encourage the radiologist, insist upon the radiologist doing a bone biopsy and not just giving you an aspirate. It largely increases the yield. It also gives you histopathology, which is very helpful. Presence or absence of granulomas, whether or not the needle went into the right place, it shows actually pathologic bone. Infection by contiguity, serial x-rays. This is a classic diabetic or a patient with vasculitis. Serial x-rays will show cortical change progressing through that period, and then you can make the diagnosis of osteomyelitis. The question about indium scan in this situation, as I mentioned, I think there is a value there, and use the ultra swab curettage in order to make the microbiologic diagnosis. But remember that infection in that setting, by contiguity, is the aftermath of untreated underlying disease. So in the diabetic, it's a matter of getting better glycemic control. And the patient with systemic vasculitis, it's about getting better control of their vasculitis. The osteomyelitis means that we have failed to that point in time. And treating the bone infection without successfully treating the underlying disease will be fraught with failure, because you'll still have the ulcer and you'll wind up with new pathogens causing the same infection, but much more difficult, if not impossible, to treat. Then introduced infection is usually much simpler. These are operated patients or traumatized patients, and the x-rays are usually very helpful, and then the debridement observations and cultures give you what you need to treat. Prosthetic joint infection. At the bone cement interface or the bone alloy interface is really the site of infection here. This really is a special form of osteomyelitis. It's not a joint infection, and we all know that, but it's just good to mention that as we go along. The cement that has made prosthetic joints a capability is polymethyl methacrylate, which was strong enough to hold the hip in place and benign enough not to interfere with human tissues, but it's immunosuppressive. And the process in the OR is heat generating polymerization process. And there's a lot of heat generated, and a lot of people think that that heat may be one of the things that predisposes to infection at that site, although the specificity of that delineation has never been shown. In other words, to show that beyond the immunosuppressive capacity of the foreign body and the polymethyl methacrylate, that the heat that's generated is actually... The roots of infection are the introduced, contiguous, and hematogenous, except it's impossible to tell the difference between introduced infection, that being one that's in and around the prosthesis that then appears at the surface by drainage, or contiguous, meaning like a suture abscess where the infection went down and caused infection of the prosthesis. So this as well. The diagnosis is really that of a painful prosthesis. Bear in mind that for every infected prosthesis, there's 4 or 5 that are painful and are just loose or have some other mechanical issues and are not infected. That X-rays and scans are inadequate because they're nonspecific, and that you're really reliant on showing that there's an organism present, and that's done before the surgery. It's done by aspirating the prosthetic joint, and then depending upon what you grow out, okay, you can then consider that to be diagnostic or not. So a negative culture doesn't mean the patient doesn't have infection, because we're assuming that there's communication between the infective site and the joint fluid, which that may not be the case. But if you do grow something out, that also may not mean there's an infection there, because unfortunately the contaminants that we're used to dealing with, like coagulase negative staph and bacillus species and diphtheroids, are also potential pathogens in this setting. And if you grow a coagulase negative staph, it doesn't mean the patient is infected, and in those situations we ask you to do a second aspiration. 2 aspirates growing the same organism with the same sensitivities makes a lot of sense that that's probably the cause of the infection, that there really is infection present, and that's the pathogen. But it's not as simple as that, and I'll be giving you data on a subsequent slide that gives you a gray zone in there that we'll all deal with together. And then once you know the organism, and once you know the infection is present, and you know what organism is, then you can decide between the different therapeutic strategies, which we'll go into in some detail. That's just putting a needle into a hip joint, and the point of giving this slide, though, is that we shouldn't be doing that, and we shouldn't be allowing the orthopedic surgeons to do this. This is a radiologic procedure, and it's important for it to be a radiologic procedure to show that, in fact, you have the needle in the proper place. It's very common for people to have needles put in without having radiologic guidance, and therefore they come out and say, well, there was no fluid there, or that the fluid was sterile, and somebody who clinically has everything going along for infection. And what patients who are often referred into the center with that scenario, and then we have a radiographically guided biopsy done, or a radiographically guided aspirate done, where the needle placement is documented, because they're basically doing an arthrogram. Okay, and then it becomes very easy to make the diagnosis by knowing that you have sampled actually fluid from the site that you want it to be at. Now here's the slide that's very, very helpful, but has, as most data collections, a gray zone. This was a very nice study that was done looking to try to see what to do with those single or 2 cultures that grow out organisms that are coagulase negative staph or other relatively avirulent organisms that either could be a pathogen, but they also could be a contaminant of the cultures. So if 3 to 6 specimens were sent in this study, but if 3 or more specimens are sent, okay, this is from the OR, in patients where there's suspicion of infection and there's a prosthesis in place, if none of the cultures are positive, there's still a 3% chance that the patient's infected because of culture-negative infections, pathogens that just don't grow. If 1 is positive, it's only a 13.3%, which I think is compatible with our own thinking about it. If 2 or more are present, that's a 20% chance of there being infection. If 3, it's 95%. So I think we're all very comfortable if there are 3 positive cultures, then that's a very high degree of probability there's infection there. The gray zone, and that 20 was actually a little gray. I tried to make that a little gray. That's a difficult area, okay? That's not a really high number for probability, but it's very difficult, for me at least, to have 2 organisms present, the same sensitivity pattern from the same patient, and just dismiss it. So I think there you really have to rely on other factors, the clinical setting and your own suspicion about whether you want to treat that patient for infection. But I think it's very clear when there's only 1 positive that you really don't have to worry about that one in the proper clinical setting where there's nothing else going along for infection histopathologically, that you can dismiss that. And that is a very frequent phenomenon because, as you know, we keep our cultures for 5 days, which is a couple days longer than other laboratories, and we do that because we need to find the pathogens in these patients more desperately than perhaps other centers. But in so doing, we probably have a higher incidence of false positives. Across the nation, there's a 9 to 11% chance of getting a false positive wound culture, so that we are commonly dealing with positive cultures that aren't always necessarily reflective of infection. So we have to have a way of deciphering which ones are real and which ones aren't. This data is very helpful. Then when you're choosing therapy, you have the single-stage procedure, which was developed in Europe. It's an exchange procedure. It's dependent upon antibiotic-loaded cement. And if the organism is sensitive to the antibiotics that are loaded in the cement, then I think that's a reasonable way of going forward in a selected patient population. It's only 70 to 80% successful, and that's not as good as the two-stage approach, which is the one that was developed actually at this center 30 years ago, where the prosthesis is taken out, the patient receives 6 weeks of antibiotic therapy, and then a new prosthesis is put in at the end of that, and that gives you about a 90 to 95% success rate with hips and about a 97% success rate with knees. And so this one has become, the sort of the classic approach, but it's nice to have another approach for those patients who can't tolerate two procedures and where they need to have the exchange procedure in order to be able to continue to be mobile. And then there's the whole group of approaches to retaining the prosthesis and trying to treat with the prosthesis in place. And there's suppressive antibiotic therapy, and then there's those situations where some people believe that you can actually eradicate the infection without removing the prosthesis. And I think that that is true, particularly when you have Rifampin in the regimen. But what we can't do is predict what the likelihood is of that success when you are stopping the antibiotics. So a suppressive antibiotic therapy is infinite for the life of the prosthesis. Finite therapy for a prosthesis in place, leaving the prosthesis in place, undetermined probability of success. Suppressive approach to treatment is ideally in those patients who have the following 5 criteria. Not just one of them, all 5. Where the prosthesis removal is not possible for some reason. So you can't go the classic way. The prosthesis is not loose. If it's loose, it's no value to the patients. It's very painful. It should come out. If the pathogen is relatively avirulent, it's a little tough to try to suppress an infection in somebody who's been septic with that organism, because if the suppression fails, you may wind up losing a life and a limb, or a limb and a life. Pathogen is very sensitive to oral antibiotics, and if the patient be able to tolerate that antibiotic, if you have all 5 of those, that's the way we actually started doing suppressive therapy here. And in those situations, they were all total hips that we were looking at that time. The success rate was 63%. But in the 37% who failed, they all retained their prosthesis on average for 3.7 years on the suppressive therapy before they failed. Failure represented having to remove the prosthesis before its time, before its expected duration of life. We have not done the study on total knee replacements. Other people have, and they've not used these 5 criteria for entry. And without using any entry criteria for suppression, the success rate is much, much, much lower. But there may be something specific about knees that make them harder to suppress, and that hasn't yet been identified. Now there comes this other group of patients where the prosthesis is left in, and the patient is given finite courses of antibiotic therapy, and there are claims of success. So in unselected cases back in the history when this all began in the 70s, the success rate was considered 20%. In fact, it was probably closer to 5% when they did follow-up for 2 years. But in those days, they did follow-up for about 6 months, and they thought that they had success at 20%. There are people who have published that if the infection arises within 1 month of implantation, that they're able to successfully treat those patients with finite therapy in 70% of the cases. And that doesn't make a lot of sense. And looking at that literature, they're claiming success with Aspergillus and with a variety of pathogens that do not make sense that you could successfully treat in that short period of time with finite therapy. And I think what we're dealing with here is a number of patients who had contaminants that were claimed to be infections, and so they were claiming to have cured an infection that wasn't there in the first place, and that's an easy thing to accomplish. Because we weren't the only center to think that that was probably wrong data, out at the Mayo Clinic, they said, well, why don't we look at Staph aureus, because most people believe that when you culture Staph aureus out, it's a bona fide pathogen. So when they looked at Staph aureus in their large patient population, if there was less than 2 days of symptoms, they had a 50% success rate of being able to treat the patient for about 4 to 6 weeks and stop antibiotic therapy and still have a successful outcome. If it was greater than 2 days of symptoms, the success rate went down to 10%. And overall, it was 36%. I think that tells a truer story. And I think in those patients that are cured with finite courses of therapy, they probably don't have infection at the bone-cement interface or the bone-foreign body interface. It's probably in the soft tissue and curable. Our problem is that we can't tell the difference between those who have prosthetic joint infections, which are just involving the periarticulate soft tissue, and those who have involvement of the bone-cement interface. So we have to treat them all as if they have bone-cement interface infection, unless there's a reason to do otherwise. And rifampin may be the future that gives us hope, because there has been a number of case reports now of rifampin showing successful eradication of infection by giving finite therapy in combination with a second agent, because you cannot use rifampin alone. But it's very small numbers of patients, and these are those where you have 3 out of 6, 9 out of 15, and 8 out of 8. And these studies from the 90s, and there have been no studies since then to look at a prospective group, which is what we need, where you're treating them with rifampin to show what the success rate is. So if you sit down with a patient and you say, I think we ought to treat you without taking the prosthesis out, and I think we ought to give you a finite course of antibiotic therapy, and we have this fine idea about giving you rifampin or another antibiotic, and the patient says, yeah, what's the likelihood of success? You'll say, I don't know. That's a little bit difficult to sell. So the thing to do is to collect the data. And anybody who wants to join me in that search, welcome aboard. But I think it is something that's probably going to have to be a multi-center study in order to get enough patients to do it. But that's what we're missing. Now, the presence of very, very resistant organisms is troublesome to us all. And when we're dealing with very resistant organisms in bone, it makes it even more difficult to be successful. Because bone infections are a little bit more difficult to treat than other tissues. And down at Wake Forest, they showed that when they were dealing with methicillin-resistant staph, whether it was Staph aureus or Staph epidermidis, whether it was total hips or total knees, they had a vastly decreased success rate compared to when they were using methicillin-sensitive organisms as the pathogens. Now, our numbers are nowhere near as bad as these, but I think there's a reason for it. And there's a very bright young man who we trained, Dr. Salvati trained, actually, who's here in the back, right? Kevin Garvin, who's now head of orthopedic surgery out of Nebraska. And he learned a few things when he was here. And one of the things he learned when he was here was to use the serum bacterial cytotiter, which we do routinely for all our prosthetic joint infections. Using the serum bacterial cytotiter to give you an even playing field, so that no matter how resistant the organism is, you counter that with antibiotic therapy to achieve a uniform level of potency against the organism, no matter how sensitive it is, no matter how resistant it is. When he did that, he was doing that routinely. When he compared his data with that of Wake Forest, he found that in his non-resistant pathogens, he was successful 95% of the time, and with methicillin-resistant staph, 89% of the time. Admittedly, a lower number, but not statistically significant. Okay, but vastly different than the comparison you saw with Wake Forest, and I think it shows the fact that the theory behind using a serum bacterial cytotiter really does hold. So. What we did in those days at the beginning of time, it was 30 years ago, was we had a choice. You could take a peak level, you could take a trough level. Those of us that were involved in it thought there were two reasons not to do that. One is that, as you see this curve of the decay for an antibiotic in the bloodstream, that neither peak nor trough look representative of the area under the curve. And so post-peak looked like it was a better shot. And the second reason was it was only one blood drawing. Okay, and the person who was doing the study was the person who was doing the blood drawing. And the idea was that we were trying to sell this to other centers so that they would also do something in a practical fashion. And so we did one blood. And we used 1 to 8 as the titer because that was an arbitrary selection, because that's what was used for endocarditis. And it turned out to be so successful that we're not able to actually look at the failure group to see whether 1 to 4 would have been successful. We don't really know that. We've towed the line on 1 to 8 all these years. Now, the other help we have is antibiotic-loaded cement. And whether I like it or not, the orthopedic surgeons are generally putting spacers into the hips and the knees. And just to give you a little history on that, we never did any of that at all, and we had the success rates that I quoted to you before without any spacers in there whatsoever. Okay? We did use cement on the reimplantation arm after the first half dozen years. But we're never using spacers. Spacers became important for knees because the knees fibrose in an important way early. That's never been the case for hips. It does make it easier surgery, from what I understand, but it is a problem because if you load the the spacer with antibiotics that are ineffective against your pathogen, then you just have a foreign body sitting there allowing the organism to potentially persist. The antibiotics that you can load are gentamicin and tobramycin, which leach out easily. Vancomycin can only be used in combination because alone it does not leach out predictably. Together, vancomycin plus aminoglycoside, both of them leach out magnificently. So they're used in spacers. They're used in the reimplantation arm of our two-stage study, and they're also used in treating chronic osteomyelitis. These are some of the data showing that you get really, really high levels in wound drainage, much higher levels than you would get just from systemic therapy. And you just can't reproduce this any other way. This is really an ideal way of delivering antibiotic therapy, period, because you get a huge amount at the target organism and you get meaningless amounts in the serum for very short periods of time. So you've minimized or eliminated the toxicity and you've maximized the potency of your antibiotic. These are the beads that can also be made of these cement with antibiotics in them, and they can be put into bone defects and give you local antibiotics by diffusion, which is really key because when we were spending that time before developing the scenario of bone death and what that represents, bone death has no vascular supply. So all the antibiotics that you give them don't get to the target. But if you put the antibiotics in the beads, the antibiotic from the bead leaches out and goes by diffusion. So then now that dead bone now will get antibiotics by diffusion, and the dead bone will become sterile. It'll still be dead, but it'll be sterile dead bone, and hopefully over time be replaced by remodeling. Last part of the talk has to do with prevention. All infectious disease talks ought to end with prevention. And this one is no different. And there's a lot that you can do in terms of prevention. And we, as the internists who see these patients beforehand, play a really vital role. There are three areas that are the major areas where patients develop hematogenous osteomyelitis of their prostheses: skin, teeth and gums, and urinary tract. So if somebody has psoriasis or eczema that's out of control, that has to come under control before they put the prosthesis in. And they have to be advised to make sure that they keep their psoriasis or eczema under control forever once the prosthesis is in place, to be a risk reducer for staph organisms from the skin getting into the prosthesis. And now particularly as we're seeing more Propionibacterium acnes cause these infections, that's also obviously part of the skin flora. The same way with dental gingiva, a lot of these patients have been disabled with their painful joint, and they haven't actually been able to go out and see the dentist. Encourage them, insist on them going to see the dentist prior to the prosthesis being put in. And then urologically, it's a classic situation for the guy to say, I was told to have my prostate taken care of, I'm going to have it taken care of right after my hip is replaced. And that's obviously the wrong order. Perioperative interventions, prophylactic antibiotics have been proven to be meritorious, and we spent millions of dollars putting in laminar flow for small but meaningful benefit. Post-implantation strategies finally have reached consensus and not uniform but close to uniform agreement in this country of using prophylactic antibiotic therapy for invasive dental procedures and for bacteremic urologic procedures. Just to tell you, in Britain, they're steadfastly against this approach. But here, we've been able to convince the dentists in a couple of workshops finally coming through with a consensus between the orthopedic groups and the dental groups to be able to give prophylactic antibiotic therapy to all patients who have inflammatory arthropathies, a disease, drug, or radiation-induced immunosuppression, diabetes, malnourishment, hemophilia, previous prosthetic joint infection, or no matter what your underlying disease, for 2 years after the prosthesis is put in. Basically, what this leaves out is patients with osteoarthritis who have had the prosthesis in for longer than 2 years. So that's the only group that hasn't been endorsed for consensus, and many of us here give those patients prophylaxis as well. It's for higher incidence bacteremic dental procedures, and the drugs you can pick from are from this group here. I have my own preferences in terms of the fact that the cephalosporins don't really do as good a job against anaerobes, which are present in the mouth, so I prefer to use things like amoxicillin and clindamycin. Those people who are worried about allergies should shy away from using amoxicillin. Post-implantation strategies then are for 2 years post-implant in infection-prone patients when they get high-risk procedures, high risk for bacteremia, and the amoxicillin, cephalexin, clindamycin grouping, and then the newest one is the urologist came on board suggesting that we use a quinolone or a combination of ampicillin, vancomycin, plus an aminoglycoside. Thank you very much.